Hello, thank you for watching. This is Maxim Shapiro, and this too is part of our important Banana Bites series. I'm going to be talking today, probably 15-20 minute conversation here, about a pre-op embo of the sphenoid wing meninge together with Dr. Passioni of neurosurgery. Now, there's a lot of good points here that I think deserve some special mention. We'll go through them all. Start with an MRI. Now already here on this MR, obviously you can see this big meninge. Presumably, we do have some important venous points that you could, from the start, appreciate these sylvian veins that are kind of wrapping around down here. So you kind of see already, you can glean a lot from just looking at this post-contrast MR, and that's going to be important. Now, a lot of edema. Something to keep in mind. Okay, move on to the angio. Left ICA injection. What do we see? Okay, a lot of mass effect. Fine. Now in the venous phase, you see these superficial sylvian or superficial middle cerebral veins, as people would call them. And indeed, it's a dominant superficial sylvian system that's draining into the cavernous sinus over here, and then out into the inferior petrosal sinuses bilaterally. So something we're going to have to pay attention to, of course, when it comes to resection. Now, this is a stereo pair, cross-eye stereo pair. Those of you that know how to do this, it's tons of insight. So try learning. We have a stereo page on the website. You can take a look at that. Now, here's an ICA injection. And in that injection, we see some tumor blush right here. And I will get to how that exactly happens. But there's something else that should be appreciated on this cavernous segment of this carotid that we're going to come back to. You can see it, you can see it. All right, now on to the external, of course, fine. It's a hypervascular tumor. We see that here. Now, some of these are better seen from frontal projections. So how this middle meningeal, all these proximal pedicles coming in there. So you can see that well on this view. Something else too. Again, a stereo pair of the lateral projection of this ECA injection. We have this anatomical background image. What do we see here? Now, if you know your anatomy, you appreciate that there's a branch here, right here, that supplies this tumor from the IMAX. Now, I'm going to, of course, give this branch a name, but you can appreciate that too. Now, of course, we do the cone beam. The cone beam CT. It's important to look at the source data so we can kind of just play this along and bear with us. Okay. Now you can stop this and you can scroll through these images like this. There's a little delay, but you can get to that and pretty versatile. Now you can start to see a bunch of things that we're going to get into. Look at that beautiful Meckel cave, huh? We're going to get into this down here. Now, what do we see? Predictably, we see this branch, which is named the foramen rotundum. Now, that gets to the whole point of like not an individual branch. It's a whole network, like anything else. It's not a single cute-looking straight branch here. It's just a bunch of supply all coming through this rotundum, right? Here's Meckel cave again. So that's important. We saw that on the ECA injection. Here's our MMA. Now, less appreciated, but also visible, is this ovale, right? Through the ovale will come, of course, the accessory meningeal artery. That might also participate in supply this tumor. And finally, this arrowhead points to what? Now, we're going to name it because you probably know it. We'll name it later, but again, on this picture, you can start to appreciate what some of the pitfalls are going to be. Okay, now, right here, you see a faint little branch going towards, you know where, right? This is a proximal middle meningeal artery, so that's going to be the Petrus branch heading towards the facial nerve canal. Okay. Now, here we start to see some little bit not so immediately appreciable, but equally important. This is the ophthalmic artery, of course. Now, here's a little hairpin turn. And that hairpin turn can be traced to this artery, which is called a deep recurrent meningeal branch. Now, that deep recurrent meningeal branch is going to here supply the tumor. That's the blush that we saw in the ICA injection, okay? And it will contribute to this lateral tentorial arcade as well. Now, at this point, we should ask ourselves, why thus, right? Why do we have all this supply to this sphenoid wing meningioma? Shouldn't we see something from the ILT or the MHT? Shouldn't this lateral tentorial be somehow associated with that? And the answer is, well, yes, except, of course, variation is the rule, right? Everything is a balance. We've emphasized that in our recent banana course, and that's our overall view of how these things are put together. Why do we see all this supply? Well, simply because the ILT is developmentally hypoplastic, right? That's the answer to all of these. It's coming from here in part because the tumor extends down low, so you might expect some MMA supply anyway, or maybe with a sphenoid wing branch. But what's important to realize is the ILT is hypoplastic, and hence all these other vessels have normally been supplying this area. So this whole area of the ILT that normally the ILT would feed was from the beginning supplied to the rotundum and to the deep recurrent meningeal. Now these have also been recruited to supply this tumor. Of course, fortunately, that also means that we have some routes of embolization, and we've done a lot through the MHD and ILT, and we published that, and it's safe with the right technique. Here you could do the same. Okay, now you can look at all of these things in the diagrams and drawings page. If you go up there, you see this picture. I'm sure you've been on the website, you've seen it. You can click on all these different numbers and see the arteries. Now, okay, now we go to the venous phase, right? That's super important. Again, this is a venous phase. It's like a, whatever, in the Siemens world, this is 3D DSA, whatever you call it. This is just cone beam CT of a venous phase injection. How to do that? Again, we've covered that in our banana course, and also we can cover that maybe a little bit in the future and how exactly to do this. But what you can see here, if we come here, is again, here's a superficial middle cerebral or sylvian veins. Now here are their veins. They're not into the sphenoparietal sinus yet, this misnamed sinus, but right here, they're kind of dumping into the sinus at this point. Now, when it comes around, just before the junction with the cavernous sinus over here, there's going to be some, oftentimes you see these little kind of like, these areas are kind of small. It's functional stenoses, if you will, or just like a sheet of dura that comes here. So it's particularly important not to injure the veins at this point. Of course, we can make this into our beautiful volumetric, volume rendered views. This is a stereo pair, by the way. Now, if you see all of that down here, there's some cool variations of the basal vein, and this is like we're seeing medial to lateral. There's some nice variation of the basal vein right here on the other side, dumping into this sinus, right? This is tentorial sinus that we talk about a lot, and here's lateral mesencephalic connection. So it's a whole world out there, not principally related to this mass, but still, this is what we see. Okay, anaglyph stereos. There's an anaglyph stereo page on the website. You can take a look at that. Get them glasses. These stereo anaglyph glasses, you could see this like that as well. Now, and then of course, our recent Venous publication. So if you click on this picture, that's encompasses a lot of these variations. A lot of this like theory of balance is contained in like all of these pictorial representations here. Click on that, you'll get to the JNS article. Okay, now we go to the embolization. So we have this, this is a headway duo sitting in the foramen rotundum branch. And we're doing kind of like a strong injection. We want to reflux into some of these septal branches and whatever, and see if there's any anastomoses that we need to be, careful to observe. Don't see anything bad. And so now we proceed with the embolization. Now, this is a foramen rotundum branch, and it's important to name it so that if there's a problem later, they say, did you know what branch you were in? Yes, I did. It's right here. We do know we do believe that particle embolization with these particular contour, which are like aspherical particles, in these settings is quite safe. So yes, we're in a V2 branch. You get it. You can embolize it through this with contour particles, and usually it's fine. Not, you know, you're not going to say 100%, but the calculated risk, generally extremely safe. And that's just a video of the typical kind of particle embolization. We don't have a flow control position. We're letting the flow take the particles into the tumor. Now, towards the end, there's another video. You see how the tumor blush is gone. So it's like the analogy is the leaves, like the leaves have fallen from the tree. It's the fall season here, by the way. Right here, we're just pacifying sort of the base branch. Now, I'd like to go into it a little bit more before we drop our coil. And it's important to drop the coil in there so it doesn't recanalize too quickly. I don't know if it makes a difference, but probably the further you are, closer to the base of the tumor, the more perfusion the V2 is going to get. So now we are on to the middle meningeal branch. Now you've already remembered that there's going to be an issue here to take care of, right? So we're doing this injection. Now this is, if you look at this, this is a frontal views. And so on these frontal views, you could see like some branches right here over the orbit. And here's that branch. Here's that meningolacrimal branch, right? And that's not a meningo-ophthalmic, but still, you probably don't want to put in particles into the orbit if you don't have to. So what to do? Well, so here's our coil in the rotundum, you see right there. Now what to do is we're going to microcatheterize this meningolacrimal branch, and we're going to close it, right? We're going to close it with some coils. Now we're going to come up and we're going to close the distal meningeal with coils too. Now we could have done that down below also. We didn't have to microcatheterize it, but it was just a little bit proximal. The origin of this is just a little proximal to where the tumor is. So I didn't want to inadvertently just like coil off some tumor pedicle and not be able to penetrate the particle into the tumor. So here we are. Now we're sitting in the spinosum. And again, we're in the spinosum. There's a proximal middle meningeal particle embo. We know there's a facial branch there. I told you that. We saw that. It's a calculated risk. Again, particles. Personally, I wouldn't do this with a liquid embolic, but I think people have, there's different kinds of techniques available. What we prefer is the same thing. We started with these 45 150s. They're small. They penetrate well. And they kind of dilute. We dilute them a lot and just get in there. And now once we're done with that, so here's a video, just injecting some particles. Now we chase it with 150, 250s. I'll probably switch to 150, 250 a little bit earlier if we're talking about like, a stylomastoid branch or a petrous branch, just to be on the safer side. And again, we get in there, stick some coil in. Okay, now what's going on at this point? Or ECA injection. There's still a little blush here. Now where that's going to come from. You remember the foramen of Valley, right? So we have this branch here, which is going to be your accessory meningeal, right? We have a microcatheter now stuck in that branch. Now we use a small, a lot of times we'll use the duo just because it's really small and you could put up to 150, 250 particles in there without too much. They don't clump inside too much. The bigger ones will. So here we are. We're in the, in the accessory meningeal. Again, we inject a little harder so we could see that. Now here's the cutaneous division of that accessory meningeal. Mostly we're, of course, in the meningeal one. So particleize that, and afterwards, this is the ECA. So now we don't see anything. Okay, now here's the post-embo ICA. This is kind of an oblique view. We see all these coils. So this is rotundum. This one is in the accessory. These three are in the middle meningeal. So like the two ones that we dropped distally and then the proximal one that we did at the end. Now you see still a little bit of tumor here. That's going to be supplied through the deep recurrent meningeal artery, right? And it's important that we take care of everything. So next we're going to go into that ophthalmic artery. It's a little bit difficult to catheterize that branch because it's really recurrent and it's not very big. But we're going to try to do that, right? No, of course, we're not going to do that. but I probably had you for the moment. Now, we have done that. It's important. Sometimes if it's a giant branch from the ophthalmic and it's a big hypervascular tumor, you can take that calculated risk, and we have that displayed on some of our cases, and we'll probably get to that a little bit later. But of course, here we're not going to go for this little thing, right? But you wouldn't put it past us, would you? Okay, so we're at the end. This is the resection. So now the resection, we're going to talk about that a little bit more. There's some surgical points that I think we'll discuss in a second installment of this with Dr. Passione. Donata will show us a video of that. Now, suffice it to say that venous preservation, all these other things were important. Now, so we're at the end. Having said all that, I do want to just show you briefly this case archives page, which has literally hundreds of cases that we've accumulated and put up there. I invite you to look at it. Because, I think there's some pretty good things out there grouped like this. And of course, the preoperative tumor embo. Here's that banana bites thing right here. Okay, listen, thank you for joining, and looking forward to more banana bites in the near future.